Great. Thank you very much, Antonio. And a couple of quick points. Obviously, we touched on this and Bart mentioned it, but I do think it's very important to emphasize to the audience this issue of the heterogeneity of disease, not only between patients, but within patients over time. And I think at the same token, again, Bart, I thought you have a very thoughtful question here. As we think about the microenvironment, I wholly agree. Why does transplant fail? And even in those MRD negative patients that Philippe described, 10% of them progressed. Where is it happening? And I do agree, rather like low-grade follicular lymphoma, where they've found that the microenvironment genotypically really matters. I wonder if the same is the issue here, and in particular is the sanctuary site in bone of critical importance in terms of targeting. And I say that conceptually because if we think about diffuse large B-cell lymphoma with bony involvement, that's a group in whom transplant fails. And that's very interesting, and I wonder if the analogy, as we think forward, is, in whom do we not cure, as it were, functionally or otherwise? And therein, I think, lies some key points. So with that in mind, I want to share with you also another concept, which is the genomic heterogeneity over time. This is from Hervé and Nikhil. The first author was Dr. Bolli. And basically, this builds on really seminal work, again, led by Bart and his team at Arkansas with John Shaughnessy and others. But this whole construct of genome sequencing and recognizing the genetic instability that we deal with in this disease is really critical. And why do I show it now? Because I want to help frame the discussion around consolidation and maintenance to an idea that how can we capture the disease, keep it trapped, keep it under control, and what are our best strategies to do it? So with that in mind, I want to generate a few ideas to share in the construct of, does consolidation behave differently after transplantation than it does before? Perhaps it does. And also, as we reset the immune system and we use maintenance as an immuno-oncologic strategy, I completely agree with Philippe that we need to understand what an optimal duration is, but I'm left with the overriding principle that perhaps we have a minimal level of continuous therapy for all our patients, and we add to that over and above in those at higher risk, just as an idea. So with that in mind, as we think about the current paradigm of initial treatment, we think about transplant and non-transplant candidates. I would argue that this definitional distinction is becoming more and more fluid as we enter the era of true cellular therapies, and of course the true exciting new era of monoclonal antibody therapy in myeloma, as well as of course the advent of checkpoint inhibition and other strategies to unleash the patient's immune system. Very quickly, this is Philippe's data, and again it just builds on the importance of what Philippe touched on, which is that VGPR matters not just pre but also post. In terms of treatment goals, I just want to frame some concepts for you. How do we improve progression-free and overall survival? Does progression-free survival always result in improved overall survival? Actually, it doesn't. So how you approach it does appear to matter, what therapeutics are in there. The risk-adapted approach is clearly justified in my view, and I hope to convince you of that. But suffice to say, we also know that there's this risk-adapted approach to outcome, which is tremendously important as we think about strategies. And this is a consolidation maintenance algorithm that I just wanted to share with you, built upon performance status, ISS, which I still think is a very useful bedside tool, and at the same time, of course, genetics in all their array, and as well, of course, as other disease features, which we must always bear in mind. So I'm just going to build a schematic, and I'm very grateful for Phil McCarthy for helping me with these particular schematics to help simplify discussion. But my focus is really going to be on consolidation and maintenance and what impact this has. I do, however, want to emphasize the importance of supportive care. First and foremost, starting with consolidation, bortezomib monotherapy as consolidation results in a significant improvement in PFS, which is important to note. And of course, Philippe already touched on the strong data from Michele Carbo and the Italian group showing the benefit of VTD versus TD. This is data from Dr. Christian Straka at ASCO last year, and in fact showing, whilst there was obviously a benefit in terms of PFS, in terms of consolidation with bortezomib, there was no benefit in terms of overall survival, which I think suggests, again, this construct of maintenance matters. Now, again, Philippe touched on this, but this is the pilot data from Marianne Roussel and Michel et al. That was so helpful in guiding us with the subsequent IFM DFCI study. What I just wanted to emphasize to you is the following, that basically VGPR rates improved across consolidation, and at least in this small study, seem to remain stable after 1 year of maintenance. But I'm going to show you data in a minute later from the larger randomized trial that shows that's actually not the case, and that across 1 year of maintenance, response rates actually do improve further, which suggests that maintenance also matters in my view. As I mentioned, we'll come back to this. This is the actual PFS data from the pilot trial. But just to say that this phase 2 was actually quite helpful. Small numbers, but informative. And what you can see here from Marianne's data is that those who were MRD positive relapsed, whereas those who were MRD negative did not. So this provided a very strong rationale behind it. So as I mentioned, I was going to talk a little bit more about the maintenance piece. And as you can see here in the larger phase 3 experience from the French trial, obviously the US trial is hot on its tail, and we'll have data hopefully in the next year or two for you, but we're barreling along in terms of enrollment. But suffice to say, there was a significant difference with maintenance, even it being only for 1 year. So with that in mind, when we think about maintenance itself, what evidence do we have for a fixed time, or if not in CR versus maintenance until progression? This is a critical question. I do want to touch very briefly on the importance of supportive care, mattering. This is data from the British showing the benefit of zoledronic acid. By the way, this was for up to 5 years, dosed every month. Again, I always have this interest in the bone in the context of a sanctuary site. This is intriguing, but suffice to say, a survival benefit was shown in this large 2,000 patient study. The Dutch group have been on the forefront of a lot of this, of course, under Pieter Sonneveld's leadership. And in this context, I want to touch very briefly on his seminal trial, which showed basically that particularly in higher risk patients with abnormal renal function, bortezomib-based therapy made a difference. This is basically describing this in the various forms. And again, in the interest of time, I'm going to move through this quickly, but cytogenetic risk also translated into an important group of patients in whom bortezomib-based maintenance therapy mattered in a way that was unexpected, arguably, when this trial was initially designed. So in terms of a phase 3 overview, this is summarized here. As you can see, we have a lot of data from lenalidomide, which I'm going to come to in a moment. Obviously, this has been led by Michelle, by Phil McCarthy, and of course by Antonio. And I did want to mention, of course, there is this preliminary evidence of benefit to proteasome inhibition in the same space. Let's focus now on lenalidomide maintenance after transplant. Now, I think this builds very nicely on some of the original work done with thalidomide-based maintenance, post-total therapy and so forth, by Bart and others, that told us that this did matter. Of course, thalidomide had its attendant toxicities and cumulative toxicities in particular, lenalidomide constituting an ideal partner in that regard. So if we look at this, and I'll just bring your attention to the right side of the curve, I think you can see very reasonably that in the context of immunomodulatory-based therapy, the benefits appear to be clear. And I would go back to the meta-analysis that in fact is going to be updated by Michelle at the meeting at ASCO. I'm going to talk about what's been presented hitherto, but there is a survival benefit shown, and it's quite striking. So in this regard, let's talk about the trials that make up that meta-analysis and distinguish some of the data between them. I think the IFM study obviously was critical, running in parallel with the CLGB Alliance experience. What's very important to note, though, is that treatment was stopped at 2 years in this study. And of course, as you see, there is no survival difference. There is a PFS difference, but because of concerns regarding second primaries, the median exposure to lenalidomide was 2 years. Now, of course, the CLGB 100-104 trial was very important because it distinctly differently behaved in a very different way. When the interim analysis was positive in favor of lenalidomide maintenance, there was a decision from the safety committee to offer lenalidomide to all patients on the placebo arm, which followed. And at the same time, however, patients continued on lenalidomide-based therapy until progression. And encouragingly, we were one of the lead enrollers to this trial. We still have a substantial number of patients on lenalidomide maintenance doing remarkably well many years out. This is the schema of the study, and as I emphasize, it builds on the 10 milligrams per day for the first 3 months, and then you go up to 15 milligrams continuously. This is another interesting point. In the maintenance field, there is some concern that this continuous dosing of lenalidomide may be less than optimal, that in fact 3 weeks on and 1 week off may be a new regime to go forward with. Anyway, suffice to say, the PFS difference is very striking, or TTP difference per the original primary endpoint, and the overall survival difference has with time, in fact, improved. And if you look at the subgroup analysis, you can actually see that there isn't evidence that if you're in CR, you don't need maintenance. If you're in CR, you actually benefit from maintenance, which intuitively makes a great deal of sense. Similarly, if you look at this issue of second primaries in the CLGB experience, this was updated beautifully by Sarah Holstein and Phil at the ASCO meeting. You can see that whilst this risk remains, it's at a low level. And if you do the censoring for it, actually the clinical benefit remains. Now, I think this is a real point, because in reality, what is dangerous about the post-transplant setting is this MDS AML setting, and it appears to be real. And we'll come back to that in a minute when we look at the results of the IFM DFCI work. In any event, this is the basic takeaway, that essentially the benefit of lenalidomide maintenance over time in the 100-104 experience continues to grow. The p-value gets more and more significant, the clinical benefit more and more striking. And just here again, another update to illustrate that point. Now, building on this has been the work of Antonio and his Italian colleagues. And just to move through this relatively quickly because it's been touched on before, but essentially what Antonio has shown very nicely is that lenalidomide maintenance after transplant until progression appears to matter. Now, what about meta-analysis? Well, the original meta-analysis that was presented at ASH a few years ago, initially when it was submitted, showed survival benefit. With some updated data that was brought into this presentation, it did actually soften. The good news with time, and especially with the update that Michelle is going to present at ASCO, this actually reinforces and shows a clear survival benefit to lenalidomide maintenance until progression. Now, how can we add to lenalidomide maintenance? What data do we have? Well, I want to acknowledge especially the work of the group at Emory, led by Sagar Loniol and his colleague Dr. Nuka. This is actually a very nice experience in a number of high-risk patients, where basically the addition of bortezomib to the IMiD platform has improved the quality of response over time, which is remarkable in my view, and the median progression-free survival has been really quite encouraging, with a 3-year overall survival signal that's striking. This is, however, phase 2 single-arm type data. It's illustrated here. The important point being that it's non-randomized, so one has to be careful about the impact of patient selection in this process. Hence our phase 3 effort. This is just a schematic of the determination trial, or IFM DFCI 2009. And just to stress that these are two parallel studies, but they're asking actually slightly, but very importantly, distinctly different questions. Lenalidomide maintenance in the US study is until progression. And I hope to convince you that that actually is a critical difference between the two trials. This is the schema which Philippe showed so nicely a moment ago. I'll be very quick about this, but MRD, led by Hervé Aveloiseau and Mikhail Munshi, has been a critical part of this study as a key correlative for outcome, and I think there's been some wonderful data generated. Already you heard this, 8.8 months PFS difference. Now that's encouraging. I will say that we're expecting a bit more than that, expecting about a year from transplant at least. That's what we would estimate from previous analyses. Now, if you think about it, just at an objective level, lenalidomide maintenance, whether you get it for 2 years or until progression, gets you 2.5 years of progression-free survival benefit. So I'd argue just at that sort of level of thinking at it at a higher level or at higher altitude, isn't that interesting? And it's very important because of the following observation. There is no survival difference. This is actually the two curves. As you can see, if you don't get high-dose therapy, it's 83%, and it's 80% if you do. Now, there's a reason for that. Basically, on the RVD arm, you can see there is indeed a higher rate of death due to myeloma. The numbers are small. But I want to bring your attention to toxicity on the one hand, not in any way to suggest that these are too toxic. They're not. This is well within the expected range. But I do want to bring your attention to this. Very small number, but only 1 case of AML on the RVD arm. However, 6 cases on the transplant arm with relatively early follow-up. Now, these obviously aren't the overall incidences. These are the deaths due to AML. So I think we need to bear that in mind, because if our patients are living 15 and 20 years, perhaps we need to think again about what we use as our platform for cellular therapy. And why I say this is this. Bart said at a meeting last weekend, and I thought it was very poignant, Bart, you used the term that melphalan is a Kalashnikov, which is true, because of course it was originally described in Russia, which is appropriate. Kalashnikov's a great gun, but I would argue we've got better guns than Kalashnikovs now. And the issue is, how do we do better? How can we generate a sniper rifle that doesn't generate the same degree of collateral damage that arguably the most mutagenic alkylator there is does? And please don't misunderstand me. I'm a very big fan of melphalan. I worked for Tim McElwain, who was the father of high-dose melphalan. But the reality is, can we now do better? And that would be my simple point about this. Tools to help us, MRD, I won't dwell on it because Philippe went through it, but the key point about MRD is it matters. One thing I do want to show you, though, that gets back to this genetic instability and to something that drives mutational thrust is this. This is data from Hervé and Nikhil. This is patient with whole genome sequencing at diagnosis, 6,000 mutations, sorry, I apologize, 5,000 mutations. At relapse, and I don't know what this patient got, we're blinded to that, 12,500 mutations. So we've got to be careful, because if we're also giving a therapy that can drive greater genetic instability in the host, what is it doing to residual clonal myeloma cells that also may be vulnerable to the same genetic instability? Again, just a thought for the future. Okay. New maintenance strategies. Philippe touched so nicely on the Ixazomib experience. Obviously, we have preliminary data to support it. This is my pleasure to show because it was published just yesterday. It also happens to, apologize. Let me go back a second. It also happens to be Philippe's birthday today, so I think it's particularly poignant. Congratulations, Philippe. I think a round of applause is warranted, if I may. And in that context, we now have an Ixazomib platform that we can reasonably add to what we do. So in my last minute, basically conclusions, post-transplant consolidation, this is what we have. This basically is a summary of a kind of US-European perspective, and I think benefits of consolidation are emerging. In terms of maintenance, I really do think there is benefit to lenalidomide, and we can build on it now. Philippe touched on this, but we have exciting new drugs, carfilzomib, antibodies, Ixazomib, vaccines, a critical area. And I'd also put in a plug for HDACs, which I think may also matter because they have immunogenetic effects as well that are important. And very importantly, as we go forward, we have to recognize the long-term toxicities of what we do. I'll stop and thank you for your attention.